Hi, everyone. Thanks so much for joining us for a special Ask the Experts Facebook Live. Today is World Lung Cancer Day. We have three Moffitt experts from our Thoracic Oncology department here to answer your questions and share the latest on this exciting topic. Joining me are Dr. Larry Robinson, a thoracic surgeon and head of Moffitt's Lung Cancer Early Detection Center, Dr. George Simon, a medical oncologist, and Dr. Jaskaran Sethi, an interventional pulmonologist. Thank you all so much for being here. Before we get underway, just a few quick reminders for our audience. Please submit your questions and comments in the chat, and we'll do our best to get to as many as possible. Please keep in mind we cannot offer personal medical advice or make a diagnosis via Facebook. Additionally, Facebook is a public forum, so any comments or questions asked here today are visible to the public, and any information shared during these events is not protected. Now we'll get underway with our first question. Dr. Simon, what are some of the first symptoms of lung cancer?
Yeah, so the most common symptoms, I sort of divide it into two categories: those that are related to the chest and those that are related to the rest of the body. The most common chest-related symptoms are a persistent cough. Everybody gets a cough every now and then, but if it persists and just will not go away, that is a sign that you need to get that looked into. The other common symptoms are progressively increasing shortness of breath, chest pain, again, a persistent chest pain, and if you have blood in sputum. So those are the four more common chest-related symptoms. Symptoms that are common with the rest of the body include an unexplained weight loss. You're not trying to lose weight, but the weight just comes off easy. A sudden loss of appetite. You just don't have an appetite. A persistent pain somewhere, like a back pain that won't go away, or sometimes a headache that won't go away. Those are hallmarks of maybe something is going on and that you need to get that looked into. There are other rarer symptoms, but those are some of the most common symptoms that I've just alluded to.
That's great information. Thank you. Dr. Sethi, I'll ask you, what is the role of interventional pulmonology when it comes to lung cancer?
Yeah, so for us as interventional pulmonologists, we often get involved in a couple of stages through a patient's journey through lung cancer. I think the first encounter we have is usually in the early stages when we are asked to help with the diagnosis and staging of the patient. So, for instance, if somebody has a suspicious finding on a CAT scan or a chest X-ray, do we need to establish a diagnosis with a biopsy? And that's part of our role in trying to get some tissue for diagnosis, along with our colleagues over at interventional radiology, our surgeons. We kind of collaborate to see what's the best approach to get the biopsy. And the second thing is we also help out with staging, because another part of the information that is needed often is which other areas may be involved, and the biopsy of those areas, especially within the chest, we are able to help out with. The other end of the spectrum is we also sometimes get involved towards the latter stages of the disease if they're causing a lot of symptoms. If somebody has blockages in their windpipe that needs to be opened up or kept open, or if there is fluid buildup around the lung that may need to be drained or are managed, interventional pulmonologist gets involved in during those phases as well.
Very informative. Thank you. If you're just joining us, today is World Lung Cancer Day. We've got three experts here from Moffitt's Thoracic Oncology Department. Please feel free to put your questions in the chat and we'll get to them as soon as we can. And just a reminder, we cannot offer personal medical advice or make any diagnosis via Facebook. Also, these are public comments in a public forum, so anything you ask here is shared and is not protected. Dr. Robinson, I'd like to chat about lung screening. This is a big topic that we're always trying to hit on every year between today and the Awareness Month in November, and really all year round. We'll start. Who qualifies for lung cancer screening?
Well, lung cancer screening with a low-dose CT scan is the only proven way to find lung cancer early, particularly when it's without any symptoms. And that's what we try to find. If we can find somebody with no symptoms and a small peripheral cancer, a small cancer, the cure rate is very high. And there's a lot of folks walking around with lung cancers right now that are curable. And if they wait till they have symptoms, they'll have later stage disease and the cure rate's much lower. So what's been found on a number of different studies, and beginning in 2013 with the recommendations for lung cancer low-dose screening CT scans have evolved. And the current recommendations for people who are considered at risk is those who are either current or former smokers who quit within the last, if there's a former smoker, quit within the last 15 years, or over the age of 50, and if they have at least 20 pack year history of smoking. What that means is if you smoke 1 pack a day for 1 year, that's 1 pack year. So that's the amount of smoking that really increases your risk. So those individuals are ones we really try to get in for lung cancer screening. And there's probably, if you take 100 of those individuals, you're going to find at least 1 to 2 will have a lung cancer, and most of those are early stage lung cancers. In the United States, it's estimated there's at least nearly 15 million people who are eligible for lung cancer screening. Yet, unfortunately, only about a little over 5% actually get screened. Florida, it's even worse. Only about 3.5% of the people are screened. So we could save an awful lot of lives and find lung cancer early if we could just get people into screening. And the reason it's not being screened is primarily a lack of education on who's at risk, both among the public and also among the providers out there in the community. I've been making a number of visits out to review this with a lot of providers, and it's getting, the information is getting out. But lung cancer screening is something that we really need to push, because there's an awful lot of folks out there could go through, have their lung cancer cured, and be back to normal in a very short period of time.
We're actually getting some questions from the Facebook audience about lung cancer screening. Sarah asks, how is Moffitt planning to reach more Floridians with life-saving lung cancer screening?
Well, in addition to just making sure that the people in the community are aware of it, as well as the providers, we're fortunate in this November, our lung cancer screening unit, mobile screening unit, is going to come online, and we'll be able to go out and offer lung cancer screening out further out in the community. A lot of times people are reluctant to, say, drive into Tampa or in the metropolitan areas, and this gives at least an opportunity. We can do some lung cancer screening out in the community with our mobile unit. This won't substitute for getting local lung cancer screening, in Sarasota or in Lakeland and a lot of places. So you can get screening. It doesn't have to be in Tampa. It doesn't have to be at Moffitt. We just want people to get screened no matter where they are. And if they can get the screening done, that's great. And we're hoping to make that a little easier for certain individuals who may have difficulty obtaining a ride, however they could get here. So that is something we're very excited about.
Thank you, Dr. Robinson, and thank you to Sarah for a great question. Dr. Simon, I'll go to you next. Once a cancer is found and diagnosed, what does treatment typically involve?
Yeah, so once a lung cancer diagnosis has been made, there are several things we have to do. First, figure out what kind of lung cancer you have. So there are 2 broad kinds, non-small cell and small cell. And then within non-small cell, there are various subcategories of lung cancer. So we try to make a full, complete diagnosis of the type of lung cancer that you have. The second thing we try to do is, by scanning methods, we try to figure out what the stage is. And lung cancer stage goes from stage 1 through to stage 4. And then we craft a treatment strategy that is individualized based on the type of lung cancer you have, what stage you are, and the sort of the molecular underpinnings of the cancer. And typically we use multiple tools. For early stage disease, we typically use surgery as a primary modality of treatment. We may give some chemotherapy before or after surgery. For more advanced stages like stage 3, we may use chemotherapy and radiation therapy, and sometimes we may use immunotherapy with it. And for more advanced stage 4 disease, depending on the subtype of lung cancer and what DNA abnormality you might have, we may use chemotherapy or immunotherapy, or both in combination, or certain pills that we call targeted therapy. So we have to first understand the type of lung cancer and the stage of lung cancer, and then we may have a team of physicians involved, surgeons, radiation oncologists, interventional pulmonologists, molecular biologists, medical oncologists. All of us put our heads together to come up with a fairly individualized treatment strategy. I like to say that treatment of lung cancer is a team sport, and it involves specialists of multiple areas to come together to give a full, broad, and very personalized treatment approach that fits each person to that person's lung cancer.
Appreciate the wonderful information. We are getting some more questions in from our Facebook viewers. Madison on Facebook asks, what are the most exciting areas of research in lung cancer right now? I'll leave that to the group.
Yeah, I'll take that. So there have been significant progress in lung cancer in the last 20 years. I'll have to say it's almost astounding progress in lung cancer. We have been able to understand the molecular underpinnings of lung cancer, and they're different for each individual. So we can now biopsy a lung cancer, study its DNA, and then tailor the treatment accordingly. We have better drugs based on the DNA analysis. We can use pills for certain types of lung cancer, and not even have to use chemotherapy and other medications. Even our chemotherapies have gotten so much better. Our drugs have become much more tolerable. We have also learned how to manage some of the side effects. Now, with several of our chemotherapy drugs, most patients don't even lose their hair. There are no nausea, no vomiting, so they look exactly as they looked before the diagnosis of lung cancer. We also have a new class of drugs called immunotherapy that doesn't kill the cancer directly, but really harnesses your own immune system to go out in lung cancer and kill the lung cancer cells. And immunotherapy drugs, we have several of them, and there are more coming, and there are more of these in the pipeline. And more recently, we've had what we call living drugs. We are able to use cancer-fighting cells, and we take these cells out of the patient's own tumor and grow them outside the body and then infuse them back into the patients. So we have made significant progress in multiple fronts in the diagnosis and treatment of lung cancer.
Yeah, and I would add to that is even in terms of the other part of diagnosing lung cancer, for instance, like Dr. Robinson mentioned, our goal is to try to pick up people in the early stages where they're potentially still curative. One of the limitations in the year past was that even if we found a small spot, for instance, we would watch it because we wouldn't have good tools to biopsy it or offer surgery right up front. In the last 5 years, the biopsy techniques have improved, and we've been able to offer robotic bronchoscopy, for instance, which allows us to get tissue with lower risk of complications. And again, it's an evolving field, which is the most exciting part, that even though things have improved in the last 5 years, we have a pathway to improve it even further going forward. And so I think on all aspects, from diagnosis to treatment and post-treatment care, we have more clarity and more improvement that's happening.
I know your team has performed hundreds of these robotic bronchoscopies in the years it's been available. How important is it for someone to come to a place like Moffitt that has the experience that this group does?
Yeah, I think it's important for patients to get the right biopsy for them. There are multiple tools out there, and not one tool will fit every single patient. Robotic bronchoscopy is one part of that arsenal, where we are able to offer some of these procedures with lower risks, for instance, to be able to get to parts of tissue, parts of the lung, which may not be accessible through other routes. Our traditional other, routes to get a biopsy is often to go in from the outside, where we're able to stick a needle in. which again does really well for a lot of patients, gets us good tissue, but has certain complications that we need to be mindful of. On the other end of the spectrum, robotic bronchoscopy will help us get that tissue with lower risk of complications too. So we kind of weigh the risk and benefits. And I think it's important for patient to be offered what is right for them across the spectrum. And so the more options that are available to the patients, the more success we have in terms of getting tissue safely.
And Pat, I think the thing to emphasize is that in any of these procedures require doing them over and over again. And the more you do them, the better you get at it. You know, it's called the practice of medicine for a reason, because the more you practice, the better you get. And with procedures, if you do them frequently, your success rate will be much higher and your complication rate will be so much lower. So in answer to your initial question, where should they get it done, is they should get any of these procedures done at a place where they do them a lot of the time and over again, and they'll have the best results.
Absolutely.
Thank you, all of you, for weighing in on that. That's great information. We are getting a question now from our audience about prevention. A Facebook viewer would like to know, what are the most effective ways to reduce the risk of developing lung cancer? Dr. Robinson, I'll let you take that one.
Well, obviously the most important one is obviously not to smoke, or if you smoke, to stop smoking. You never get completely away from the risk of lung cancer when you stop smoking, but it drops dramatically when you stop smoking. So that's probably the first thing to start with. There's a number of, there's a whole laundry list of risk factors for lung cancer besides smoking. Exposures to all sorts of other agents, even cigar and pipe smoking increase your risk for lung cancer. Smoking marijuana, anything that you put into your lungs outside of pure air increases your risk. Now, it's not as high, nearly as high as, say, with smoking itself. Also, exposures, occupational exposures, can be a real problem. Everything from arsenic and burning fires, all of these things outside, significant air pollution, all of those, if the best you can to avoid them. Another problem, which we think is problematic with a lot of different kinds of cancer, is other aspects of your lifestyle. Exercise, which is a real problem that we're trying to get people to do. Obesity, which is an epidemic in the United States and is associated with a number of cancers. In fact, just reading a nice article about millennials and Gen Z, increased risk of cancers early in life, and they appear to be all related to the obesity epidemic, because obesity increases the inflammatory reaction, you end up with chronic inflammation in the body, a number of other factors, and increases your risk of cancers. So there's things in your lifestyle besides stopping smoking. So the big thing is exercise, keeping your weight down. Your diet's important. Probably processed foods markedly increase your risk of all sorts of cancers besides lung cancer. So a healthy lifestyle is probably the best thing. It's something your mother would tell you to do, but it's so important when you talk about decreasing the risk of lung cancer and many other cancers.
Is there a genetic risk for lung cancer?
Yeah, there's an increased risk, particularly if you have say a first-degree relative, like your mother or father or brother had lung cancer, you have a slightly increased risk. If they were smokers and they got lung cancer, and you're a smoker that gets lung cancer, or your risk, I should say, your risk of lung cancer is much higher. Basically, if you're a smoker, your chance of getting lung cancer is 1 out of 6, which is quite considerable. However, if you have a first-degree relative who was a smoker and got lung cancer, particularly when they're early in life, your risk is probably down to a 50-50 chance you're going to get it.
Dr. Simon and Sethi, I saw you both nod your heads pretty big when I asked that question.
Yeah,
Anything
I agree with everything that Dr. Robinson said. The genetic predispositions for lung cancer is not as well defined as it is for breast cancer or colon cancer. So we know that there's BRCA1, BRCA2 genes, that those are increase your risk for breast cancer. We know the Lynch syndrome and APC syndromes, they increase your risk for colon cancer. But for lung cancer, we still are not entirely sure what those genes are. There is rarely you can see a gene called T790M that can be transmitted in families. And those have been known to increase your risk for lung cancer. Excuse me. So yeah, I agree. The best marker for a genetic risk of lung cancer is having a relative who already had lung cancer, a first-degree relative. And if that first-degree relative was a smoker and you are a smoker, you have to be really careful. And the best thing to do is quit. And it's never too late to quit.
And the only thing I would add is in terms of the risk factors, maybe not so applicable here in Florida, but lots of our patients who live in Florida also have houses elsewhere in the country. Is there are some parts of the country where radon is pretty high as well, especially if you live in a part of the country where basements are common. And so it's important if you are living a significant amount in that area to get it tested and mitigated, because some studies in parts where radon is high have shown that as much as 15-20% of lung cancers can be radon related as well. So that would be another consideration, especially if you have housing outside of Florida that you spend considerable time in.
I would love to learn a little bit more about, what exactly is radon. You sort of mentioned it's not a big concern here in Florida, but
Yeah,
what do we really need to know about radon?
it's essentially it's an odorless, a colorless gas that is generated as a breakdown product of usually uranium in the soil. And if it's a well ventilated space, it's not much of an issue. It'll get dissipated in the environment. But often the issue arises is if you are in a closed space, like I said, in a basement or closer to the ground where there may be leakage of this gas into your environment. And what has been shown is it's not necessarily a short-term exposure, but more of a longer-term exposure to these gases increases your risk of lung cancer particularly. And there is some data suggesting some of the other form of cancers as well, but most established is probably for lung cancer. But it is a byproduct of some of the constituents in the soil, particularly uranium. And it doesn't have any odor to it, doesn't have any color to it. So a lot of the people that are exposed to it have no knowledge of it unless they test for it specifically.
I don't know anyone in Florida with a basement, so hopefully
And
none of our
it's
are worrying
not
about that.
necessarily very common. The soil isn't really high risk for radon exposure here in Florida, but in some of the northeastern states, particularly New Jersey, out west towards Colorado, Utah, those areas do have higher instances of radon.
That's great to know. Thank you. Getting some more questions from our audience here. Yadira is watching on Facebook. She would like to know, are these screenings free of charge or at least covered by insurance? And if they are covered, is there a referral needed? Dr. Robinson, I'll let you take that one.
Well, Medicare, if you're a Medicare patient, they're covered completely. And generally all insurance companies now are sort of mandated to cover screening if you meet the criteria: over the age of 50, 20-pack or history of smoking or more, and quit smoking within the last 15 years, or a current smoker. And virtually all of those do. Occasionally we'll have, for example, here at Moffitt, we'll have patients who are under the age of a Medicare age and may not have adequate amount of insurance. So we do have vouchers here at Moffitt that can cover the cost for patients who do not have the insurance coverage for that. So it is generally covered. We just have to sort of hit all the bells and whistles with the right codes, which is sometimes a pain, as insurance can be a pain, but generally it's covered by everyone. So people can self-refer, or your physician. Most of the time, it's the physician will ask you to go ahead and get your screening CT scan.
That leads into my next question for you. What if you have some of the risk factors, or not all, but you don't qualify for a CT screening?
Well, that's a big question, and that's a concern. Roughly, if you sort of do the math, if everyone who is eligible to get CT scan screening, and we would find about half of the lung cancers every year. However, there's about half of those lung cancers are in people who don't meet those criteria for screening. And then we know there's a whole laundry list of things that increase your risk. And the more you add together, the increased risk. If you have a first-degree relative who smoked, say, and you worked in an industrial area where you exposed and maybe lived up north for a while, may have had radon exposure, the more of those things you add together, the increased risk you have. So it's a common thing that people ask. We're not sure who to recommend. As I tell folks, if they're really concerned about it, their physician, and you ask your physician to refer you for a CT scan. It may not be covered by insurance, but the cost for out-of-pocket, a cost for a low-dose screening CT scan here at Moffitt, I believe is around $175. So, about the cost of a family of four going out for dinner without wine at a reasonable place. So I think if that peace of mind, sometimes that's all that's needed. And you'll find a number of people who have lung cancer who don't meet those criteria. So I think that's something to consider. We're trying to get a better handle on who else we should recommend lung cancer screening to, but that's still up in the air. If you want to see the list of things that are risk factors for lung cancer, if you go to moffitt.org and put in lung early detection in the box at the top where they ask you for questions, it'll give you a nice brochure that discusses all about lung cancer screening. And in there, it has a list of around 18 different factors that can increase your risk of lung cancer. You read through this and it'll give you a lot of information.
Yeah, and at the same time, I would say just like what Dr. Robinson had touched on before about the other things you can do to reduce your risk of having lung cancer. Those things, if you're concerned, I think you continue to do those things, work with your physician team and see if you're appropriate for screening and if there's enough concern to get a CT scan, and just reduce your risk as much as possible. I think that holds true for everybody, but certainly for people who even have some risk factors in between.
That's great information. Thank you both. We are getting some questions from the Facebook audience surrounding treatments on the horizon. I'll start with a question from Jeremy. What's on the horizon for anti-PD-1 therapies? Are there any new FDA approvals coming? Dr. Simon, I'll give you that one.
Yeah, anti-PD-1 therapies and very similar to anti-PD-1 or anti-PD-L1 therapy. So they are monoclonal antibodies that target this particular protein, either PD-1 and PD-L1. And what these drugs do is the tumor is able to shackle the immune system and prevent the immune system from attacking it. And kind of one of the shackles they use to shackle the immune system is this PD-1, PD-L1 pathway. And this can be blocked or interrupted by these drugs. And so now PD-L1 or PD-1 inhibiting drugs are now routinely used for stage 4 lung cancer with chemotherapy or by itself. It's also used in stage 3 lung cancer after chemotherapy and radiation therapy has been given. And it's also now used for stage 2 and certain stage 1 lung cancers where the patient has had surgery, and then you are given these drugs for a year or so to prevent the cancer from coming back. So drugs like anti-PD-1, anti-PD-L1 drugs have now become very common in routine use. They can be in stage 4 lung cancer, and even in earlier stage lung cancers like stage 2, it can be used with chemotherapy, even sometimes before surgery or after surgery. It can be combined with other immunotherapeutic drugs like CTLA-4 inhibitors, and those have been combined and used in stage 4 lung cancer with a particular kind of molecular phenotype. So there are several other immunotherapeutic agents that are being studied, and those are in research stages currently.
Sticking on the topic of treatments, TIL therapy is something that's very exciting. There was an FDA approval for TIL for melanoma last year, the first approval for a solid tumor. I know Moffitt's involved in clinical trials for TIL in the lung cancer realm. What should our audience know about that, and how exciting is this that now there's hope for the solid tumor world?
Yeah, so these are entirely a new class of drugs. Like I said earlier, we call them living drugs. So TILs are tumor infiltrating lymphocytes. So lymphocytes are your own immune cells that are able to kill cancer. So TIL therapy, the one that is approved for melanoma, is called lifileucel, and they are being studied for lung cancer as well. And so this is basically what you do. the surgeon goes in and take a piece of your tumor. And then the T cells, your own immune cells that are attacking the tumor, are then extracted from those T cells, from the tumor. And then they are grown in bags in labs outside the body. And they are grown and to a proportion where there are billions of these cells. And once you have an adequate number of cells, then you're given a high dose chemotherapy to suppress your own immune system. And then those TIL cells are then reinfused back into the body. So that's how TIL cells work. And now these cancer-fighting cells, T cells, now that are in the billions, are infused back in the body. They go in, find the tumor cells, and they kill them. And unlike drugs, which tend to dissipate after some time, these cells can continue to live for days. And so they go in and kill one cancer cell and then go on and kill the next cancer cell, and so on and so forth. So they're circulating in your body, finding tumors and killing them. And in a study done, reported last year in lung cancer with a particular kind of TIL therapy in patients who had basically failed most other kinds of therapy already. So these are patients who are pre-treated, heavily pre-treated, had failed chemo, had failed PD-1 therapies. These patients were given TIL therapy and they found astounding responses in 25% of these patients. Now, we now know that if we do it earlier, before they're heavily pre-treated, we may even get better response rates. And another advantage of these therapies is that sometimes they can be durable. So these tumors can stay in partial remission for months, even after one TIL therapy infusion. So these are very exciting therapies, and they are already used in several liquid malignancies, hematologic malignancies. They are now approved for melanoma, and they're being studied for several solid tumors, including lung cancer.
Something that, is really exciting about what we're doing here at Moffitt is, that recent FDA approval, that's sort of, an early generation of TIL. Our researchers are already working on second, third, and so on generations. What does the role of clinical trials play, in what we do here at Moffitt, and especially when it comes to lung cancer?
Yeah, no, clinical trials are an integral piece of cancer care. I tend to tell my patients, patients who participate in the clinical trials with PD-1, PD-L1 therapies in 2016, 2017, those days we did not know exactly how well these drugs worked. But those patients who were treated in 2016, 2017 essentially got 2023, 2024 treatment 7-8 years ago. And so these newer drugs, the way we develop new drugs nowadays, we have taken the guesswork out of it. And we are now able to tell fairly reliably that whether these drugs have a reasonable probability of working or not. In the olden days, what we used to do is we used to grind plants and leaves and roots and extract chemicals. And then we used to squirt it on cancer cells and see whether they worked or not. But nowadays, new drug discovery has been, changed dramatically. Now what we do is we identify a protein that we know causes cancer cells to grow faster. And then we make drugs which are not present in nature. These are completely man-made drugs that go and block those proteins and prevent the cancer cells that from growing. So we now know that those particular drugs that have been developed in such a way will work for those patients who have that protein in their cancer. So we can now also tell which cancer patients those drugs will work in. So we have basically taken the guesswork out of the drug development. And you were saying, Pat, earlier that T cells, the next generation of T cells, there is a new generation of T cells called CAR T cells. CAR T cells are even more exciting. Here we just connect an IV line to patients, and we take T cells from your blood, not tumor infiltrating lymphocytes, but just T cells that are circulating in your blood. Then we take them to the lab, and then we grow them into millions of cells. And then we modify those cells. We train those cells by modifying those cells, by telling them how to find a particular protein on a cancer cell. And then these modified T cells are then again grown and expanded into millions of cells. And then those are infused back into the patients. So CAR T cells is another area that is being studied for lung cancer, and it's already being used in lymphomas and other liquid malignancies. But that's the next generation of what we call cellular therapies. And many of these studies are available at the Moffitt Cancer Center. And sometimes they offer hope to patients for whom previous drugs have not worked. So cancer research is, in my opinion, an integral part of cancer treatment, and offer hope to patients who may have exhausted other lines of therapy.
That's great information. Dr. Robinson or Dr. Sethi, before we move on from the clinical trials topic, anything you'd like to add?
I think that we must emphasize the need for patients to be open to clinical trials. I think it's gone from the point of, oh, they're just experimenting on me, until your chances of doing better are with a clinical trial than just sort of standard of care much of the time. Because usually, again, clinical trials are usually based on having one arm, if it's a randomized trial, to the best known therapy, and the other arm is to best known therapy plus something else. So you actually, being in a clinical trial, your outlook is actually much better than if you just say, I'll just stay with what's currently around. So I really have to emphasize the importance of, when patients come into a large center like this, which has an enormous number of clinical trials available, that they really be very open to participating in trials, because it will likely have an extraordinary benefit for them, not just for future patients.
I agree. I often tell my patients, standard of care drugs today, what we call standard of care, they've developed in the 1990s, early 2000. So if you stick to standard of care treatment, you're essentially getting 1990s treatment, or early 2000, late 2000 treatment in 2024 to 2025. More immunotherapies are developed in 2015, 2016, 2017, but you're getting drugs that were developed 5, 10, 15, 20 years ago. To really avail of the latest research and the latest developments in cancer research and cancer therapy, clinical trials is a way to is a way to participate in and access those treatments. Yeah. And because those treatments are not FDA approved, the only way a patient can sometimes get those treatments is through a clinical trial. And again, I'd like to emphasize that we have taken the guesswork out of the system by understanding in whom those drugs are most likely to work. And we don't give it to those patients in whom we think that a particular marker is not there. And if we know this particular drug works, if you have that particular marker, then we don't give it to those patients who don't have that marker. We give it to those patients who has that marker. So we have actually taken that guesswork out of the system. And like Larry said, we therefore are able to show that a higher proportion of patients will benefit from these treatments.
Yeah, and it's such a rapidly evolving field, and it's due to these clinical trials that is actually, I think, like Dr. Simon said, the standard of care is now clinical trials in a lot of aspects as well, because that is what offers more precise and more even more updated treatments than is available otherwise.
It's certainly an exciting topic and a big topic. Thank you all for your valuable input on that one. We've got a few more questions from the audience as we're coming up on our time here. But Facebook question is, how can patients advocate for themselves within the healthcare system? Dr. Robinson, I'll give you that one.
Well, I think the real thing that people need to realize is the person who has the most vested interest in their own health should be that individual. So don't just sort of wait for somebody to call you about getting the test you're supposed to get. You know, healthcare providers are fallible. Things get lost. So if you're told that you have, for example, a lung nodule and that you need to have a follow-up CT scan in 6 months, and you haven't heard from anybody, or they haven't scheduled you for your CT scan, you really need to contact whoever was going to do that and verify that happens. Because, like I say, it's not a perfect system for sure, and everyone realizes that. So take control of your own health. Be aware of when you should get studies done. If you're recommended a certain treatment, don't be afraid to get a second opinion. Don't just assume that everything is what you are told to do. I tell people, don't be sheep. This is a time where you need to be aware of what your options are. And if you're either uncomfortable with a recommendation for surgery or some kind of treatment or radiation, you name it, you know, and you're uncomfortable without that, I would definitely get a second opinion. And I see people for second opinions all the time. And they may stay with what I recommend or go back where they were, but they'll be more comfortable. And I tell my family and friends, if they have a disease entity, whether it's lung cancer or anything else or suspected cancers, they need to be sure to be aware of there's options, and there's a lot of different possibilities. And so for example, get a second opinion. Follow up on your own tests to make sure it's not lost.
Very
agree
valid.
with that, and I agree with that. And I think, you know, seeking out the expert in the field, and we alluded to this earlier, you know, if you need a portion of your lung taken out, you want to go to a surgeon who does only lung resections and do 1,000 resections, you know, hundreds of resections a year. And similarly, that's true for procedures. You want to go with somebody who does robotic bronchoscopies and have done those day in and day out, every day for years. And so the more a surgeon does the procedure, the better the results are. This is even true for medical oncologists. There are medical oncologists who have focused their careers on a specific disease, like lung cancer. And so they are now familiar with the nuts and bolts of the disease, so the drugs that are used, the side effects to expect, the latest clinical trial. So you want to seek out a expert in the field who does just that, and then advocate for yourself. Most of us, you know, call back our patients with results, but sometimes I tell all my patients, if you don't get a call from me by this particular time on this particular date, then you call me. So I always have a backup system to make sure that, you know, redundancy is always good, so that we make sure that patients are called back in a timely manner.
All right, we've got time for one last question. This is from our audience, and I'd love to give you all a chance to answer it. I think it's a great question, and I want to hear what you all have to say. The question is, how do you envision the future of lung cancer care evolving, and what changes are you most hopeful about? Dr. Sethi, I'll start with you.
Yeah, I think the future, I think, for us is, unfortunately, lung cancer, even as of now, has the highest mortality amongst all cancer. So I think whatever we can do to reduce that metric is what we would like to focus on. But that's obviously a perfect world, right? And that's not the case. So that's why the advancements, I think, are happening on all fronts, which is the exciting part. So we would like to see more and more people get screened, detected with early cancer, and have curative. He's not a candidate for that, get sustainable, durable response with minimal side effects with the therapies that are being developed. So I think I think the exciting thing is the work is happening on both ends in parallel. and that is what is needed. And so I think that is why I think the future seems much more bright from lung cancer therapy perspective. And I stay hopeful from that all perspectives.
Dr. Simon, we'll go to you next.
Yeah, all right. So I think, we envision a future without cancer, and this will take all of us. And the best way to not deal with cancer is to prevent it. Okay, so have a healthy lifestyle. Don't smoke. Use alcohol in moderation. Stay away from polluted areas. Have a healthy lifestyle. Exercise. Have a diet, a Mediterranean diet full of fruits and vegetables. So prevention is one of the ways of ensuring that we all have a cancer-free future. Second step is screening. Everybody who needs to get screened should get screened. I cannot emphasize that enough. The best way to cure cancer is to find it early, whether it is getting CT scans of the lungs for CT screening for lung cancer, whether it is getting mammographies, whether it is getting colon cancer screening. Please, everybody should get screened. Do not delay that. Take it as recommended. Do it as recommended. That screening saves lives. And many of those cancers can be found early. And then getting to the treatment, early stage cancers can be cured. Even lung cancer, which is one of the more aggressive cancers there is, if you find it early, we can cure them. We cure the vast majority of stage 1s and a significant majority of stage 2s. So find them early. If you're still unfortunate or have a cancer that is more advanced stage, what we have more and more become successful in is try to convert an incurable disease into a chronic disease, a disease more like diabetes or hypertension. Patients can live for years with these diseases. You just go to your doctor, get a blood pressure checked or a blood sugar checked, and adjust your medications accordingly. So we have become more and more successful over the years to convert incurable diseases into chronic diseases where you can live with these diseases for many, many years. So my plea is have a healthy lifestyle, undergo all the screenings as recommended, and try to detect these cancers early. And if you do have cancer, then we follow the guidelines to get the most effective treatments so that we can cure many of these. And if you're not able to cure them, at least we are able to live with them for decades.
Dr. Robinson, I'll let you close this out.
Well, I'm just going to say, and sort of the second on what George had said, I think it's critical that we get more people in for screening, because what we'd like to see is what's happening now, and that's a stage shift. And what I'm talking about is there's a shift of stage from late stage disease to early stage disease. We've gone up tremendously in just stage 1 lung cancer, which is a curable lung cancer. Now it's at least 25% of the people who are now found to have lung cancer, it's stage 1. I'd like to see that up to 50% of the people who get lung cancer to be stage 1. And we could really do that if we can get people in for screening. And that's not just for lung cancer. We're talking about all of the cancers. It's estimated that at least 90% and maybe more of cancer is lifestyle. It's not your parents. You can't blame your parents. You can't blame anybody else. It's the lifestyle you choose. And what George was saying is so critical. You can prevent most of the lung cancers and most of our other degenerative diseases of any kind, whether that's stroke, Alzheimer's disease, and so on, by changing your lifestyle. That is keeping your weight down, changing your diet, exercise, and staying away from exposures, a variety of different exposures that increase your chances of getting a variety of cancers. So you have a chance, you have a choice, and you need to make that choice and not realize that you'll get eligible for these cancers. When we're very young, all of us are bulletproof. We do, what's going to happen to me? Nothing's going to happen to me. And then when you get to be about 40, 45, 50 years old, you start to realize that those things that you've been doing are going to start increasing your risk. So the time to start is not when you're 70 years old. It's fine to start when you're 70 years old, but you have to start the young people to realize that what you do determines your health span, not just your lifespan, but how long you stay healthy.
Thank you all so much for your input and your time today. And thank you to the audience for tuning in, asking great questions. Again, today is World Lung Cancer Day. For more information on that, you can visit our website, moffitt.org.